Going to the emergency department is not the same as going to your doctor. I bring this up because I saw a video earlier today from a woman who has about 4,000 followers. And she's into self-healing, that sort of thing, which is interesting. That's fine. And she also has a phobia towards healthcare providers, towards physicians and other people that must wear scrubs and that sort of thing. Understandable. I get that too. She apparently had had hip pain that had been going on for, sounds to me like a few weeks. Sounds to me also like she probably consulted some friends of hers about, gee, what do you think this could be? And I think the general consensus was, well, maybe this is bursitis or something like that. But then she developed a little bit of a skin eruption and became pretty concerned pretty quickly. And so she went to the emergency department. Now, she describes this whole scenario as, I went to my doctor. Let's be clear. She didn't go to her doctor. She went to the emergency department. But what's interesting, and I guess the whole point to be made here, is that when you're going to the emergency department, you're not going to your primary doctor, and you're not going to get the same evaluation that you would get from a primary care provider who has an established relationship, or at least should have an established relationship with you, who can work up a problem over the course of time in cooperation with you, to make you the partner in identifying whatever this problem might be. The emergency department is for emergencies, right? We know that. We also know that people sometimes will go to the emergency department simply because they don't have anywhere else to go. Either they don't have a primary doctor, or they think that it's urgent enough that they don't want to wait to get in to see their primary doctor. And that's an issue because sometimes you'll call your primary doctor and, let's say it's March, and they'll say, okay, great, we'll see you September 20th, so that doesn't help. So it's understandable. I get it why people come to the emergency department for all of these reasons. But nevertheless, the expectation of what some people have and what they ultimately get when they come to the ER are two different things. In the emergency department, we are concerned with what is the worst thing that could be happening to you? What's the most life-threatening thing that could be happening to you? And that's what we're going to look for. And that oftentimes means, yes, we're going to do blood work, we're going to do imaging, we're going to do things that probably aren't all that necessary, but nevertheless, we're not going to let you walk out the door with something that's life-threatening. So sometimes that means doing, a lot more testing than what maybe we do in a primary care setting, where I could have you try this and then call me in 3 days and let me know how it goes. And then maybe we'll try something else and kind of just, handle this longitudinally. Anyway, this lady, she went to the emergency department. She had a rash or a skin eruption on her hip. And this was the area that had been painful for, sounds like, a couple of weeks. And she described the doctor as quick, but impatient, high and mighty, didn't like a lot of questions, and kind of thought he knew everything. So, think about it from the healthcare provider standpoint. You're seeing not just one patient, you're seeing 10, 12, 15, 20. You might be supervising people that have their own 15 or 20 patients that they're seeing. So it's not uncommon that an attending physician in the emergency department might actually be overseeing 30, 40, 50 patients. Not impossible. And so when you go in and you interview a patient, you really need to get right down to the crux of the matter, right off the bat. What's going on? What's the most life-threatening thing that could possibly be going on? Let's address that. And then most other things can probably be handled as an outpatient through your primary doctor. That's more or less the way, we approach just about everything. But when somebody comes in with, a vesicular rash on the skin in an area that's painful, along a dermatome, along a pattern of where a nerve lies, then I think you can make the diagnosis fairly easily that this is probably shingles. And it sounds like that was the case. But she demanded a CAT scan. And she said, quote, "I really wanted to know what was going on." So I don't know how many times I've heard that, but a lot. This presents a whole separate dilemma because you want to be responsible not only with antibiotics and pain medication, but you want to be responsible with imaging. You don't want to image everything because it's radiation. It's also cost. But beyond cost, it's radiation. And particularly if you're younger and you have a lifetime ahead of you, which who knows what is going to happen down the road, but you may wind up needing CT scans or other ionizing radiation at some point down the road. So we really don't want to CT someone who doesn't obviously need it in order to aid in the diagnosis. But it sounds like this scenario played out where the physician was probably bullied into getting the CT scan. This lady doesn't really say what the CT scan showed, so we can assume it didn't show anything, which makes sense. But she was just overall just very disappointed, very negative with her experience in the emergency department. Sounds like the physician offered her pain medication, ibuprofen, and she said, "Why would I take ibuprofen? You know that ibuprofen can cause X, Y, and Z problems, and I just don't get how these doctors today just want to push pills on you." And so I said, "Absolutely not. I'm not going to take the ibuprofen." Okay, I've been in that situation before. I'm like, okay, I understand. I respect that. That's fine. And then the physician apparently also offered her Lyrica. And this is for nerve pain. It's not something that I've typically prescribed for shingles. You know, usually it's an antiviral. Although she's had this symptomatology for a couple of weeks, so it's questionable whether it's going to be helpful or not. Apparently she was offered that, and she declined that also. And she was really incensed when the Lyrica was offered to her. It's, well, you want to put me on a lifetime medication. You just want to create just a perpetual patient. And believe me, the ER doctor does not want to create a perpetual patient. The ER doctor is planning on seeing you one time and one time only, and that's it. He or she doesn't care about creating a panel of patients to come into the emergency department, every 2 or 3 months, or, well, in some cases with our folks, every day. Anyway, she was really just making the point that the whole healthcare system is set up to just push pills, and that no one cares, and that we're all high and mighty. And she doesn't get the point that as much as I may sympathize and as much as I may really want to help you, I do have to draw the line as to how far I can go in the emergency care setting. I mean, once I've determined as best as I can that you're not dealing with a life-threatening condition, then it's time to move on to the outpatient management, whether it be to a specialist or your primary care doctor or whatever it may be. With the caveat that if anything changes, if anything gets worse, you can always come back to the emergency department. You're always welcome to come back. This just struck me because obviously, as I've said, I see this a lot, and I'm sure anyone who works in an emergency department is going to say the same thing. So this lady's video just sort of triggered me. I hate the word triggered, but it just kind of really made me think, all right, got to put a word out there to people that may watch this video that are not necessarily in healthcare, that the emergency department is there, it's open, it takes all comers. Anyone can walk in with any sort of complaint. I don't care if it's a hangnail. You can come in and we will take care of you. But we're not going to take care of you and then proceed to manage your diabetes and your high blood pressure to the nth degree. I mean, if you come in with uncontrolled hypertension, we're going to treat that in an emergent fashion. If your blood sugar is 600 and you didn't know you had diabetes, then we will get you either admitted to the hospital for further management, or we will somehow point you in the right direction. We won't leave you hanging. But not in every case is that emergency department visit going to fix every problem. So, and I think this is true. A lot of people will leave the ER and say, well, I saw my doctor and my doctor said that, everything was okay. No, you did not get a clean bill of health after your ER visit. You got a bill of health that said that as we examined you that day, you had no obvious life-threatening conditions. Or if you did, we addressed them. So, anyway, I hope that makes sense to somebody out there that might be wondering, should I go to the emergency department for X, Y, and Z condition? If you don't have a primary doctor, which, let's face it, a lot of people don't, then the ER, unfortunately, is probably where you're going to have to go. But when you do come, just have a little bit of understanding that we're going to do the best we can to help you with your problem. But it may not mean that it's a one and done, that you're going to be treated that one day and then you're going to be good for another 10 years. Just, we can't do it that way. If we did, we would never make any dent in the waiting room, which you'll notice when you come into the ER, that waiting room is going to be pretty darn full. And when you finally come back into the ER proper itself, you're going to notice that our hallways are filled with patients sitting in chairs, laying on stretchers. You probably will have a chair somewhere in the hallway yourself. And you're going to realize that if we followed up every single thing to its ultimate end, we'd never see everybody. It's just the way it is. So anyway, thanks for listening to that little bit of a rant, I suppose, or whatever you want to call it. But hopefully it helps some people understand. If you're in healthcare, I know you know this kind of stuff. You don't need to necessarily hear this, but it's too late. I'm saying it at the end of the video, so it's too late for you. Anyway, look forward to seeing you on the next video. Take care.